Good afternoon, everyone, and welcome to our webinar on physician suicide awareness and prevention. I'm Lily Belfi, Chair of the AUR Ad Hoc Wellbeing Committee. We're pleased to bring you this programming today in conjunction with the APDR and the AUR R&E Foundation. The format for today's webinar will be presentations by our panelists, followed by approximately 30 minutes of live Q&A and discussion. You will be able to submit comments in the chat box and questions in the Q&A box at any time during and after the presentations. We are recording today's webinar. Our panelists today are Dr. Christine Moutier, who serves as Chief Medical Officer for the American Foundation for Suicide Prevention and has testified before the U.S. Congress, presented to the White House, and at the National Academy of Sciences. She co-anchored CNN's Emmy Award-winning Finding Hope, Suicide Prevention Town Hall with Anderson Cooper, and has appeared as an expert in the New York Times, the Washington Post, and other outlets. Dr. Isabel Newton is an associate clinical professor of radiology and interventional radiologist. She is a physician scientist at the VA San Diego and UCSD. At the VA, she is chief of IR and wellness director of radiology. She has 7 years of experience in resident and fellow education, having served as co-director of the T32-funded Clinician Scientist Radiology Research Program and program director for interventional radiology. She recently participated in the Stanford Wellness Director course. She is a trained peer supporter, and she has been an active member of the UCSD HERE Committee since 2014. She will tell us more about that. My co-moderator today is Dr. Elise Desperito, Assistant Professor of Clinical Radiology and Vice Chair of Education at New York Presbyterian Columbia University. Elise brought the idea for this webinar to our committee and has been a driving force in the collaborative efforts to bring us all together today. Elise?
Hi, everyone. I'm going to share our story, my story at Columbia with everyone. And then we'll go from there. So many times since that day, the day of his death erupts into my consciousness, and words and images come back to me. Like the hospital security guard bending down to look through a small hole beneath the round doorknob of his apartment and saying, "I see a leg." I have been silent for a very long time. His mother has given me permission to speak about his suicide, as long as I honor his privacy and his family's privacy. She is allowing me to speak, she said, if it will save other doctors from dying. I'm going to call our resident John. This was not his name. John had not shown up to rotation in nuclear medicine that Monday morning in September. He was a first-year resident. We always pair our first-year residents with a senior resident on their rotations. The senior resident texted one of the chief residents late in the morning to ask if the chief resident knew where John was. The chief resident did not. The chief resident then started to text, call, and email John starting at about 11 a.m. He never got any responses. At 12:30, the beginning of resident conference at Columbia, the chief resident texted me, I was the program director at that time, to say that no one could get in touch with John and that he hadn't shown up for his rotation. He asked if I knew anything. Had he told me he wasn't going to come to work? I said no. My texts and emails and calls then started. I didn't get any responses over the next hour either. At 1:30 at the end of conference, I walked over to the resident conference room from breast imaging. During conference, the chief resident had texted John's fiance, who had not moved with him to New York for residency. She had come 2 to 3 weekends before, went out with a bunch of residents. So many of them had met her. There was even a picture up in the resident lounge showing them all together at a restaurant, smiling and having a good time. His fiance told the chief that she had spoken to him late Sunday night. he was home and that he told her he was going to call his parents when he hung up with her. She said they talked about at 11 p.m. When I heard this, I asked our program coordinator what his address was. He lived in hospital housing a few blocks away. I turned to the chief resident and I said, let's go to his apartment and see if they know anything. It was a gorgeous New York September Monday, very similar to the day the World Trade Center was bombed. The sky was a deep turquoise blue. Puffy cotton ball clouds drifted as we walked quickly up Fort Washington Avenue to hospital housing. The chief resident was furious. He said to me, this better not be the beginning of a long year of a problem resident. But John seemed like such a strong candidate when I had interviewed him. His grades were stellar in undergrad and medical school. His recommendations were excellent. He had spent 2 weeks with me on breast imaging in August. He was quiet for sure. Most first-year residents are. He was attentive and involved on rotation. He was clearly reading because he was asking good questions. I was more worried than angry. The apartment management team let us in the building. We knocked on his door, no answer. They did not have a key to his apartment. Protocol was to call hospital security. We stood in the hallway of the old apartment building for more than an hour before the hospital security guards arrived. Large white linoleum squares covered the floor and the bright September sun streamed through the huge old windows, enough to make you squint. The chief resident had been texting and calling John this entire time, still no answer. We couldn't hear John's phone ring in the hallway either. The two guards banged loudly on the apartment door multiple times. They were convinced he was asleep and they could wake him up with the banging. They even climbed through the window and walked out on a ledge to see if they could peek through a window. The shade was down, an air conditioner blocked the window. John never came to the door. The apartment management team had been rolling the camera footage to the building this entire time. They reported that John was last seen entering the building on Sunday afternoon at 3, the day before, and he never left. He had to be in there. They had to call NYPD. The chief resident texted his fiance, who was his emergency contact, and told him he couldn't find John. She said she was going to call his parents and let them know we couldn't find him. As we were waiting, one of the hospital security guards poked an opening through a small covered hole in a hole below the doorknob, probably the old keyhole that had long been covered. He crouched down and looked through the hole. As he looked through the hole, he waved his partner over and said, "I see a leg." His partner then took a turn to look. I was behind him and I said, "What do you mean you see a leg? Let me see." I looked next. The pressured discussions began. We were not allowed to break down the door, the law. We had to wait for NYPD to get there. The chief resident and I told the hospital security guards that we were going into the apartment once the locksmith opened the door, no matter what. Maybe we could still save his life if he wasn't dead. 9/11 had been called, but they weren't there yet. They told us no. We told them yes. It was our duty to try to save his life. The minute the locksmith opened the door, the chief resident and I walked quickly into the apartment behind the security guards. There was a long, narrow hallway that led directly to his body. There was no question he was dead. NYPD quickly ushered us out. It was now a crime scene. The yellow plastic tape went up. As the noise of people and commotion grew, more NYPD, EMT, detectives, and people. My phone rang with a number I did not recognize. I picked up. It was his mother. I held my APD's hand as I spoke. "Did you find my son?" she asked. I said, we have found his body." She said, "He's not alive." I said, "No, I'm so sorry. He is not. She screamed a sound that I don't know if I have ever heard. She said, "We're coming," and hung up. The sadness of this story is overwhelming. I will tell you, I had no idea the degree to which he must have been suffering. No idea. His fellow residents had no idea. It was an absolute shock to all of us. It is tragic and traumatic. So how do we go forward from this? What can we learn? How can we be better? How can we save this from happening? I met Dr. Christine Moutier last year when she spoke at Columbia for National Physician Suicide Awareness Day on September 17th. She came to speak to our Columbia community on a panel in honor of Lorna Breen, one of our beloved ED physicians who died by suicide during the COVID surge in New York. Christina's come to speak to us today about physician suicide, and Isabel to talk about her amazing work in our community of radiologists. So thank you for listening to my story.
Thank you so much, Elise and Lily and the AUR team for convening this important session. So let me just pull up my slides. And also to Isabel Newton, my dear friend and colleague, who will make comments after I give you a brief presentation. So it really is my honor and my pleasure, and thank you so much, Elise, for your courage to share your very personal experience with physician suicide. Many of us have been touched by the experience of our own personal struggle, a colleague's struggle, or the loss of a trainee or physician colleague. And that is certainly how I got my start in suicide prevention now at the national level for the whole population in the US. But it really did start with my own experience of losing colleagues. And so for the next 15 minutes, I'm gonna very quickly, and I apologize in advance for going fast to cover the data and the points that I want to share with you. But I want to start with just a start and end, actually, my part with just a very quick continuation of how I got involved in suicide prevention at the national level. And it happened for me. I was a practicing psychiatrist and training director, and then eventually a dean in the School of Medicine at University of California, San Diego. And after experiencing my own struggles as a medical student, which sort of primed me for an experience to understand that the culture within academic medicine was not syncing up with that of a human being with normal life struggles, let alone mental health struggles. And then over a period of 15 years, there were numerous suicides of our faculty physicians across all specialties in the health sciences at UCSD, 13 suicides in total over a period of 15 years. And during that period of time, I was rising up, on the faculty and was a dean in the medical school, and was essentially sort of charged with by my boss's boss, the big D dean, with, in his words, get to the bottom of this. Meaning, how many people have actually died by suicide? What is going on? Can something be done in the work and learning environment that impacts a population's mental health and suicide risk or prevention? And it's really actually a very significant question, which, even though I had an interest at the time, I did not know the literature very well. And now we know that the environment syncs up with one's internal factors and has actually quite a bit to do with stigma, with help seeking, with whether you're allowed to even speak about your own internal experiences of struggle or suicidal thoughts. And so my dear mentor and colleague, Sid Zissik, and I essentially took a couple of years, formed a committee, which Isabel's going to tell you more about. The HEAR committee stands for Healer Education Assessment and Referral Program. And that program has now been going on for about 13 years. And And so it was boots on the ground that I learned a lot of what I'm going to tell you, but it's from my role as a national suicide prevention expert and leader that I'm going to try to kind of pull it all together to help make sense of the issues, what amounts to risk, and what can constitute effective suicide prevention. So just a little bit of level setting here. In case you have not been kind of exposing yourself to the literature on physician well-being, and it's sort of hard not to over the last decade or so, it is absolutely the case that physicians and healthcare professionals who pay attention to our own physical and mental health really optimize our ability to preserve our maximal ability to take care of patients and to stay in the game of the practice of medicine with all of its complications and challenges. So that is sort of the premise that that it's not a sign of weakness, that it's actually a sign of strength to take care of our mental health, because it does preserve our optimal resilience. And I think what I had lived over that decade or so as I was, in my own career path in academic medicine, was with my personal, internal, sometimes secret agenda and passion around suicide prevention, was honestly a whole lot of resistance. Because at the time, it was not necessarily spoken of widely to discuss issues of mental health amongst our own human selves and our colleagues. However, I'm really thrilled to say that, not thrilled to say this, the problem of physician suicide has been an millennial and an infinitely long-standing problem, but we weren't able to talk about it. It wasn't recognized. And if you're like me, when suicides are occurring at your institution, unless you are close up to it, like Elise was in that instance, you don't necessarily know what's going on in the other clinical departments. And so no one is necessarily talking about it. And that is kind of the shroud of silence that can be there when an issue and an experience is highly stigmatized. Well, what happened in about 2014 was, starting, honestly, I think it was the ACGME who their leadership and board were personally affected by the suicide death of a resident whose family was in Chicago, where they're headquartered. And at the same time, 2 medical interns in New York City who died by suicide within a short period of time of one another. And they really took it on. Their board of directors was in tears at one meeting because of those experiences. And it finally had sort of penetrated head to heart and readiness to take action. And what we've seen since then is the National Academy of Science, the AMA, the AAMC, the Federation of State Medical Boards, really every other national leading medical and other healthcare disciplines associations are tackling issues at least related to burnout, but usually more than that, meaning depression, addiction, suicide, risk, and prevention. Now, this is just to say that in some strange ways, the field of medicine is a little bit behind, just in that if you look at what's happening around us in the sort of local media or national space of media, very well-known musicians, athletes, celebrities of all different sorts are talking about their experiences of suicidal thoughts, suicide loss, or mental health struggles and experiences. And it's a positive conversation where stigma is being shed, and where they're saying, and we're saying, mental health is part of human health, just like physical health is. And we all need to start talking about that so that we can be proactive, strong, and smart. That is happening now more and more in the field of medicine, with stories like this one, Dr. Michael Weinstein in Philadelphia, a trauma surgeon who wrote his story in the New England Journal of Medicine. But you see it now in social media and probably every issue of JAMA and many other publications. So it certainly is a time of culture change in a very positive way. Let me just make a few remarks about what we know from the science and neuroscience of mental health and suicide, just again, to just kind of get on the same page a bit. So mental health is a full continuum, just like physical health is. The term mental health used to be used really kind of referring only to mental health conditions, psychiatric illness. And that doesn't really make sense because mental health is health. So it's along a full continuum. And for any of us, we might be at any stage from suffering to languishing all the way up through flourishing. And it's okay if we're not always flourishing, if we're in that sort of middle zone of coping and sort of fluctuating. And especially during COVID, it's been just a different time for all of us. And so even if you're paying attention to your mental health very kind of fastidiously, it can take effort actually to stay in the coping to performing realm and not slip into that languishing realm. The diagram on the right is really just to kind of put something into a visual that's in my head, which is that mental health is extraordinarily dynamic, meaning that we have genetic underpinnings. We have biological and neurobiological mechanisms that are constantly processing stress and manifesting in various aspects of our behavior, thought, perception. And it's a constant interaction of those internal sort of factors that interact with one's external environment. And that's where the culture of medicine comes in. And if your colleagues and your leadership and just the unspoken air around you sends a strong message that these are not aspects of being a doctor, that we are not allowed to talk about these things, that will drive the experiences underground like it did for so long and make suffering go on and worsen and potentially turn into much more severe conditions, threaten the possibility of suicide for physicians, and can impede patient care as well. Now, there's a few other factors that really need to be stated here, because you might say, how is it that we are one of the most educated fields? We all went through a psychiatry rotation, and yet, and what I'm going to show you data that shows that physicians actually have a higher suicide rate than the general population. How is that? And so in addition to those kind of environmental, cultural factors, we do have a tendency, now we all have different personalities, we're different individuals, but something draws us to medicine and allows us to succeed. So we are helpers, healers, caregivers, and we have the compulsivity and the perfectionism that sort of creates that perfect combination that allows us to get into medical school, to succeed, and to move up in the ranks. However, if you think about the traits that are required to have a healthy relationship in your life with the significant other, or just to be a healthy human being outside of the workspace, they are not these qualities. They're actually qualities that are quite different. They're qualities of flexibility and compromise and being able to hold ambiguity and the uncertainty, the messiness that life presents every human being. We plan as much as we can, and then life throws us what it does. And in a relationship, we have different perspectives. So guess what? That attitude of perfectionism and that sort of type A drive can be very detrimental in a relationship. And so for our own mental health, it sometimes gets in the way of help seeking and of just being honest with ourselves about the experiences that we're having. And what I want to say is that it's not about changing who we are. It's about being savvy so that we don't have just one dial and volume on high all the time, because different situations and different aspects of our life warrant different coping skills and strategies. Now, what the suicide literature tells us is that in every instance of an attempt or death by suicide, it is multiple risk factors that have come together like a perfect storm, kind of like I described about mental health, that there are internal and external factors. And of course, lethal means and the knowledge about what constitutes lethal means is sort of a necessary and pivotal ingredient in that perfect storm of suicide risk. But I say this because I want to point out that our human minds want to look for one reason because we crave answers, especially after a personal experience of loss of an individual to suicide. And you may find clues, certainly, but just humbly keep your brain in check by realizing that those may be factors, and there are factors that we can't see that have to do with family history, genetics, biology, and experiences and distorted cognitive negative assumptions about oneself. So many times people who are suicidal and in a suicidal crisis believe that they are a burden to others. They believe that those around them would be better off without them on this planet. And it's a cognitive distortion, which when you're not allowed to express it, just kind of can snowball and fuel itself into a state of much higher suicide risk. And that's one of the reasons that we think talking about our experiences is such a very important first step. And we'll talk about how to do that safely and very constructively. So just what the data is just huge now. There's a very large literature, especially related to physician mental health. Now also a growing literature related to nursing mental health and other health disciplines. But basically, when it comes to depression, and suicidal thoughts and suicide deaths, we as a group have higher rates of all of those mental health related experiences compared with age matched and gender matched general population cohorts. Now, this is just a fascinating finding that in one study by Tate Shanafelt's group, 275 physicians who actually their well-being index score was very low. So compared to their peers among physicians, they were suffering with lower, quantifiable well-being index scores. But 71% of them in the bottom 30% believed that their well-being was at or above average. So it is very challenging for many of us to calibrate our own level of distress and sort of have an objective view of when it constitutes something significant that we need to do something about. In other words, it's normalized in large part. We know that COVID has been a significant experience, but I also want to say that these issues were long-standing and deep and severe before the pandemic hit. And so it is compounding in the sense that we had that baseline level of distress. Now, depending on what field you're in and what your role has required of you during the pandemic, mental health and experiences of distress may have worsened, and they have for many, many physicians. And there are still significant barriers to care, although I do think one of the silver linings of COVID has been that we are more willing to talk about it, and more resources were actually created so that physicians and other frontline workers can safely connect to care. But it is also true that we shouldn't be thinking that when the pandemic ends, it will just sort of magically we'll all just sort of come back to our best state of well-being and mental health. Because in fact, if there have been traumatizing experiences during the pandemic or before, trauma often manifests on a much, much longer timeline. And so the human instinct, we psychologically gird ourselves for a period of time so that we're either actually able to continue functioning well and may not be fully aware of the impact on our mental health for even months or years later. And we know that of combat veterans as well, that oftentimes those symptoms of PTSD really don't fully manifest, let alone come to medical attention for years. For time's sake, I think I'm going to just skip through some of this. There's lots of data about the impact of COVID on the healthcare workforce. The barriers to care are there, but what I want to say is even with the issues of licensing, which we can discuss, I believe that it's more about our internalized beliefs, our own self-stigma, and the stigma that we think our colleagues have. And so this is a fascinating thing, that if you are somebody who has come to terms with mental health as truly a part of your own health or your family member's health, but you think that your colleagues all believe the old way, it's going to be a hindrance to you being able to take action in the most proactive way possible. Now, there's something very important in the literature, which is that among physicians who are struggling, so there's actually a study, a psychological autopsy study of physicians who died by suicide, published by Katie Gold in 2013. And the physicians compared to the general population suicide decedents had the same level of mental health problems, conditions, and distress, but they were less likely to have connected with formal mental health care. And in fact, there's a lot of other literature that shows that physicians who are depressed, anxious, suicidal, are more likely to self-prescribe or to receive a psychotropic medication from a colleague in an informal way, because it feels like, you know, they're reaching for something that will give them relief in the short term. Of course, we would all want to do that, but what they're not able to see is that they are taking away the opportunity that you would afford to anyone else in the similar circumstance, which is a formal full evaluation and professional health care, so that you have a point of support and check-in and the usual adjusting of treatment that we all need. And so oftentimes these are short-term fixes. They're ways to help your sleep or help your sense of agitation or panic, your inability to concentrate. But what you're not seeing is that there is a larger picture of distress that warrants a full treatment plan. And I just want to tell you that in many, many instances, the vast majority of medical students, residents, and faculty I worked with, and there were hundreds over that decade I was a dean, not treating them, but advising. It is very, very safe to seek treatment without negative ramifications. Now, we can talk more about that, because I realize that's a very sweeping statement and there's a lot of fear. But having lived deep in that world of physician treatment and help seeking, I can tell you that it is the extremely rare instance that came into issues with the state medical board or a hospital privileging committee. During COVID, after Lorna Breen, the emergency department physician in New York City, after she died by suicide, ASAP, the American College of Emergency Physicians, and many, many other organizations came together to really understand their population better. So this is about ED docs, and it shows that, for example, there's still tremendous stigma. There's tremendous reasons that they are avoiding mental health treatment, that many of them are still, they're struggling, but unable or feel unable to connect with care. There have also been advocacy efforts to work with the Federation of State Medical Boards and each of the, at the state level medical boards, to get those questions about mental health on the licensing form changed. Okay, just a couple more points to make. So there's been a longstanding assumption that I think drives some of the stigma, which is that mental health conditions are always impairing and always jeopardize a physician from being able to safely practice. And that is a complete myth, in the same way that it would be to assume that hypertension, diabetes, and any health condition would be automatically impairing a physician practice. I think that the problem has been that it's been so underground that by the time physicians are seeking treatment, oftentimes it's being mandated and they've already had problems with practice. And so what I want to say is that in my life and in hundreds, maybe thousands of physicians that I've known over the last couple of decades, when help seeking and treatment occurs in the usual way, which is when you detect that you need an evaluation and you want to link up with treatment, it does not impair or harm people. It improves performance. It prevents future negative impacts that can be negative. And so one way to think about therapy in particular is to think about elite athletes and executives who would really not probably, unless they're confused in some way, they would not avoid seeking the most expert way to have their mental frame, their mental health set optimally so that they can perform if you're an athlete, so that they can make clear decisions if you're an executive. So just very quickly, there are individual and organizational level solutions, and I'll just touch on these super quick. I've published on this resilience reservoir because it just made so much sense to me as I was sitting with people over and over, kind of sensing where they were in their level of resilience. And so I want to say, like, just picture that we all have this reservoir of resilience. It's a substance. Just go with me on this. And that's what we're drawing from every time, every day we're facing frustrating challenges. There's something we tap into that allows us to just keep our calm, stay mentally engaged, be compassionate, be flexible. But there are things that naturally drain that reservoir. And even if, you know, he had nothing negative happening in your life, there's just a natural sort of draining that's happening. But there are things that can absolutely fill up our reservoir, and it's up to us to engage in those activities. We can be doing a lot of self-care, maintaining our sleep, exercise, stress management, really paying attention to our relationships, not assuming that we are a victim of our circumstance. And so it's really about self-reflection, learning, and being a scientist, really, about your own life and how you tick. This was a model that I used with lots and lots of trainees and medical students. And it's really, during COVID, you can think of it, about psychological PPE and how do we protect ourselves by keeping this resilience reservoir strong. But it would be totally inappropriate to think that it's all on an individual. There are institutional strategies that must be done in order to create an environment where these kinds of activities and help seeking can safely be accomplished. And these are just a smattering of examples of types of strategies, whether it's just simply connecting in some facilitated, systematized way, whether it's educational initiatives, something like the talk that I'm giving you right now, all the way to, you know, building things into the curriculum related to resilience building, mindfulness, stigma reduction. And there are a number of places under barrier reduction that are using a very multimodal program that that seeks to impact the entire population to kind of elevate the level of resilience and change culture. And ultimately, in the case of the UCSD HERE program, one of the goals is actually to reduce suicide risk as well. And so you'll hear from Isabel more about the HERE program, but just so you have a framework when she speaks about it, we started in 2008 or 2009 with a two-pronged approach: education combined with the interactive screening program. And these were our goals. And what I would say is, over the years, there were, even in the first several years, there were a number of immediate kind of short-term gains, and then there have been longer-term changes and gains. And so it really, in hindsight, was a contributor, I believe, to the positive culture change that has been happening there. No place is ever perfect. It's always a work in progress. But there were signs right away. For example, there was a very rapid bump up by about 40% in the percentage of the medical student body that connected to the mental health services on campus. And so if you don't know what's going on with a program like this, you're going to see that data and you're going to go, oh my gosh, the student body just got a ton sicker, because, you know, a much huger number are now connecting to care. But that is what always happens when you destigmatize these issues of mental health experiences. And over the 12 or 13 year period, it's been over 600 physicians and trainees who've been referred to some sort of support, in most cases into mental health treatment. And that has likely been life-saving overall, because, as I mentioned, in the 15 years pre-launch of the HERE committee program, there were 13 physicians who died by suicide. And in the last 12 or 13 years, there has been one, it was a medical student suicide that occurred. These are some physician-specific resources. So if you're looking to, kind of post these for your trainees, I would actually highly recommend the physician support line, which popped up as a new resource during COVID, and the Emotional PPE project. They offer free advising, and in the case of emotional PPE, treatment of any physician who calls, and it's very anonymous and safe. But there, at AFSP, we have a whole web page that's devoted to this topic. If you just put in your search engine AFSP physician, you'll come to a page that has all of what I've talked to you about and more. So I will stop there and turn it back over to Elise, I believe.
Thank you, Christine. So many important and helpful things to think about. So I want to turn to Isabel for now. And Isabel, if you can tell us about your program, how you started, where it is now, we would love to hear.
Sure. Thank you so much for this opportunity to be here. First of all, I just want to congratulate you all and the AUR for taking this incredibly important step. In my experience, as radiologists, we are some of the most steeled medical professionals. We kind of see things in black and white, both literally and figuratively. And so programs like this are important first steps towards opening the conversation. And so I joined the HERE program right after my IR fellowship, and this was stimulated by an incredible talk to the GME by Dr. Moutier, who was at that time in the thick of starting the HERE program. And part of that is an outreach. And so we, different members of the HERE committee, give talks on burnout, suicidality, depression, resilience, and substance abuse. And these kind of the scope of the talks have increased even during the time that I have been a member of the committee. We then encourage anybody who is distressed, or in fact, everyone, so we have a good denominator, to take this short quiz, basically, that is produced by the American Foundation for Suicide Prevention on our website. And that identifies people who are in distress and then gives them an opportunity to anonymously connect with trained counselors, like coordinators, who they can then talk with and then can connect them to further services afterwards. So it's really about outreach, it's about increasing awareness, and it's about giving medical providers, these are trainees, allied health providers, residents, attendings, the opportunity to get services. And one thing that we've really been trying to push at UCSD is to offer these services off of the medical record and free of charge to trainees, because that's one of the biggest barriers. And so this program has been extremely successful, and it has also been modeled at other institutions and has sort of set us to be the resource when there are times of distress. So as Christine mentioned, we have had a decrease in suicides. We did have the one that was absolutely devastating, but we've also had trauma. And we have been the go-to resource for helping our institution deal with traumatic instances. We had a terrible car crash that killed 3 medical students and injured 1. And we kind of were able to mobilize into action. So I'll stop there so we can stay with the Q&A.
Okay. Lily, do you have a question?
Thank you. Thanks, Elise. And thank you so much to our speakers today for these presentations. We have some questions coming through the chat box and the Q&A box, which I'd like to offer up to the group, if that's okay with all of you. So the first question is, do you think that the change in landscape of medicine over the past decade, specifically the increase in mid-level providers, more residents graduating with fewer residency spots, less job stability for new or established physicians, fewer independent doctor practices, corporate healthcare employing more doctors, et cetera, is contributing to the mental stress / moral injury of physicians, leading to a higher suicide rate? Or is this high suicide rate in physicians steady / unrelated?
Well, the suicide rate itself is very hard to track in a granular year-over-year way. We have data, it's too much to get into, but suicide surveillance in our country is solid, but takes a long time and is not terribly granular when it comes to occupational status. So we're going more on research studies that do a dip into a few states, like the Katie Gold suicide study. So it would be difficult to actually say with any level of certainty what direction it's trending in, and that's a problem in any public health matter or effort, when you can't really track your results of concentrated efforts. But of course, at an institutional level, that can be done. And I do know that the ACGME, which did a deep dive for all-cause mortality over a 10-year period, which was published in 2017, I think it was, they're about to revisit that same data set and update it, that would include during the COVID period. So that would at least tell us something about residents and suicide. For that decade previously, suicide was the leading cause of death among male physicians and the second leading among female physicians. But for residents, it was actually the rates for both males and females were lower than their age-matched general population cohort. So when we talk about it being higher, we're talking about the research literature that was really looking at the entire continuum, and it's thought that it's more at the mid-career and beyond, which is true of the general population in terms of suicide rates being the highest in midlife and then later.
Thank you. We have another question here in the chat that is radiology related. So Isabel, perhaps you can weigh in on this as well. Many of the things that exacerbate depression are endemic to radiology: isolation, absence of movement, sitting for hours, dark working environment, and routine disruption, alternating day and evening, night work, and weekend work. This is especially problematic in private practice, where studies indicate 85% of our residents and fellows will work. How do we encourage systemic change or support those who may wish to leave the profession?
I think this is an incredibly important point, and it is actually resulting in a lot of people reducing their hours, going part-time, or choosing not to work as a radiologist at all. And that's a huge loss of talent. There has to be a culture shift that embraces our own humanity, our need for breaks, our need for sunlight, for exercise, and not to stigmatize it as if you are somehow a weak person. And that begins with residency training. And that's why, AUR is such an appropriate leader in this space to set the expectations for how we are going to raise the radiologists of the future. And I truly believe that this can then influence the culture in the workplaces of people who have already been trained before. One of the great things that millennials have done for us is they have forced us to recognize that there are times to stop working, and there are times to to pay attention to work-life balance. And so I do believe that if we can integrate a little more of this during our residency training, and this means actually putting the primacy of residency education above staffing issues. And so sometimes, we have to say, it's time now for you to take a break, go on a walk, and have residents practice cooperative sort of support. So one will cover the phone, or one will cover, the list while the other one goes. And these things are built into the residency program. If we don't do this, we're basically in a commodities race to the bottom. We're devaluing what we give to our patients and to our hospitals. And so another way of enriching what we do is to involve more interactions with patients. It could be on the phone, or actually if we're in the hospital, to go to the clinics, the emergency rooms, and see these patients that we have such a great impact on. That adds value to the patients, to the referring physicians, but it also enhances our fulfillment. And I do believe that radiology is going to move away from volume to value. And value is to be able to understand that when you offer this litany of differential diagnoses, that instead of doing that you narrow it down and make it more appropriate to help our colleagues, our referring physicians, to make better diagnoses.
Thank you, Isabel. Right, that's your points are really spot on, and I feel like, as a medical community at large, and as the radiology field in general, this shift is happening. It's happening as we speak, and I think it will contribute to wellness of overall. for us and our patients. Another great question in the Q&A box. It reads, in business, initial success leads to praise and overconfidence, setting up companies for future failure due to complacency and lack of receptivity to the need for change, AKA the Icarus paradox. In medicine, including academics, we also have so many high-functioning, often high-strung performers becoming known as paragons of success, some or most of who will face failure at some point in their careers and lives. What approaches and concrete steps would help individuals deal with these setbacks, especially with blows to the ego and reputation and perceived failure to live up to expectations?
I can start, and then anyone else who has thoughts. I mean, I think it's a really excellent point, and I love that picture you paint, because I see our culture and our makeup very much in the same way. And so there have to be active messages that are part and parcel to medical school, residency training culture, the work environment that promote a different mindset that is more about a growth mindset that says there will be challenges and failures. That's a given. Let's make that our starting point, so that we're not shocked, so that of course we will feel embarrassed and humiliated. I mean, we're all humans, but that we've already been primed to understand that that's part and parcel to the life of a physician, and that it's not the end of the road. And I think so changing culture is we did that at UCSD through that two-pronged approach: education, destigmatization, and then that interactive screening program. The point there being with the ISP that all the education and culture change in the world is not necessarily going to sync up with the person in their moment of distress, and especially suicidal crisis, because there's a whole cognitive constriction that happens in that moment. And so it affords the opportunity to connect with those higher risk individuals in a way that's safe and anonymous. And the last thing I'll say is, the more you're able to have narrative storytelling sessions where people talk about the challenges and that the arc that they've been through that may have been really challenging, but that there was hope at the end of it, that has been studied, actually, that storytelling arc in entertainment and in journalism, and has a very positive mental health and even suicide preventive impact on the population.
I just want to jump in real quick and say that this really is the definition of resilience, to find an opportunity that's challenging or stressful and turn it into a growth opportunity. And if we use as our starting point, as Christine says, and also at the same time recognize the things that our residents are already positive and strong at, and say, everybody's going to have strengths and weaknesses. So when you fail, it's really an opportunity for us to focus on ththings to make you a fuller, more complete person. But let's at the same time recognize that, your interpersonal skills are exceptional, or, all of the colleagues are very, always you're the go-to person. So I think you can do it in a balanced way that makes us all realize that we're in a constant state of growth.
Yes, thank you for those comments. It brings to mind the term failing up, and the importance of recognizing failure as progress and steps towards success. We have so many great questions coming in. One that's actually been iterated a few times is, how can we identify the risk of suicide in trainees? Sometimes we need to be tough on some trainees because of poor performance, but are we putting them at high risk for committing suicide?
I mean, I think you have to be able to train and have continuous improvement feedback. You can't, that's part and parcel of medical education and training. So I think it's in a way, I think we are conflating issues of performance and self-esteem, and that is real and important, and mental health and vulnerability and suicide risk, which can certainly intersect with those moments, but understanding that the vast majority, while it might be tough to get, constructive feedback, people will be fine. And so I think you have to think creatively about, again, training your residents so that as peers, they have eyes on, training your faculty about warning signs and risk factors and how to engage trainees that you are worried about in a supportive, caring conversation where they understand that is separate from performance. So I want to really reiterate, if you think about suicide risk in the health framework, and it's separate from performance, sometimes they intersect, but sometimes so does physical health and performance, right? So when you keep it clear like that, I think you're much better served by coming up with all the things that can allow your training environment to be, as rigorous as it needs to be on the learning and performance end, but also safe and supportive in terms of being a place where people can have those kinds of conversations. And I do think it starts with some modeling, like maybe has already been discussed, that person you were kind of describing of, the go-to resource that, top of their game. If they're an individual who can once in a while weave in a story about their own failings, humanity, struggles they're going through, help that they've received, and if you're that person, you might think that's going to downgrade your status. It won't. It will upgrade your status because people will be drawn to understand that connection between being real, authentic, getting the help you need, and being a high performer.
And
Yes.
Just to follow up on that same question, I'm sorry, Elise, any specific things to look for? This is a question that's been coming up a lot to the panelists. Specific signs of struggle that may be red flags, not only in trainees, but in our own colleagues?
I would say trust your gut. Your people around you and their behavior patterns are pretty darn predictable. So when they go outside that range, and understand that you're like one spoke in the wheel. So if there is mental health deterioration or suicide risk brewing, there are probably nursing staff and peers and chief residents who are also having eyes on and seeing their own things. So there's a way to either use the team, or if you're not ready for that yet and it's too stigmatizing, then just approach the person yourself in that caring, supportive dialogue. And I can talk for a moment about how to set that up and do that. The bare bones is set it up, don't have it in the hallway in passing, meet them for coffee or in your office in a private space, and be very direct and say, I wanted to speak with you because I noticed X, Y, and Z. Tell them exactly what you saw and immediately follow that with, and this is because I care about you and I want to be supportive of you. There is no judgment. This is a judgment-free zone. It's to really understand what you're going through and make sure that you're getting the resources and support that you need. And then just stop. And you could just stop right there, or you could ask them an open-ended question and let them talk. And then the cues are if their tone or their words are sounding hopeless, overwhelmed, trapped, or like they feel like they're a burden. That is a moment when to follow it up with the question of, when you talk about, use their words, it makes me wonder if you're having any thoughts of ending your life. Let them talk. So that's the general flow. And I know that might sound very scary, but I want to remind people, you are not their clinician, you are not their therapist or their doctor. So they can, if they reveal something private to you, like suicidal thoughts, you say, oh my goodness, thank you for trusting me and for sharing that with me. And I want you to know that you're going to get all the support that you need. So remember that 6 to 12% of medical people are having suicidal thoughts. So the fact that you've just opened up that dialogue is a very positive thing. And it doesn't mean they're about to act on it necessarily. Probably not. In 99.9% certainty, that's not how it works. In fact, the fact that they're sharing it with you means that they're trying to determine how they can get their needs met. You would probably be shocked to know how many people around you in the training environment are having suicidal thoughts at different times. And I'm not normalizing that, but I'm explaining that that exists. And so if you intersect with it in that caring, supportive conversation, you can just stay with it and have the conversation before you determine what action needs to take place.
Wow, thank you.
I wanted to add something important about what you just said, Christine, and that is that so often with program directors and associate program directors, the having time, so much of it is time, because what you're really speaking about is developing a culture of trust so that And that is time. And I think it's so important that PDs and APDs advocate for their protected time to do the work that they do. There are ACGME requirements around that. And if they are not getting that time, they should go to their division head, they should go to their program, their chairman, and say, look, this is required time for me as a PD or a APD, because I think developing that culture of trust is being present for residents, not at that semi-annual review that we do twice a year, but all the time, getting a cup of coffee or just being around. And I think that's so important for PDs to advocate for themselves to get the time that they should have to do their work.
In these discussions, as you've so beautifully outlined an approach for, there have been several comments and questions coming through about any legal concerns. I'm sure this is something on everyone's mind when approaching someone or trying to have these discussions with a trainee or another colleague. Is there anything, any pointer or pearls to keep in mind?
The main thing I would share is along the lines of what I already did share. Think about if you were worried that they had, you name it, physical health wise, cancer, sprained their ankle, whatever, what would you do in that circumstance, or in the discussions and the dialogue and in the support that that resident would receive? And if you keep it in that and you document it as such, completely separate from performance. Now, if there are performance issues already going on or intersecting with that, then that is something to also take note of and have good documentation for. But I think what people think is that maybe if I just avoid it altogether, that I will somehow be less liable, avoid their distress. The truth is, if it were to come to light in a courtroom or whatever kind of proceeding, having existing programs where support or messages of the resources, where a program like the interactive screening program or anything like that, the EAP, any resources are available, and where they are messaged and where the culture promotes that, those are protective things for the organization as well as for the population.
I don't want to disrupt our flow here because this conversation is really important, but I do want to honor and respect everyone's time. So what I'm going to ask is, for those that do have to leave, in a few moments, there will be a SurveyMonkey link for your feedback posted in the chat. It's only 5 questions. We would appreciate your input. And for those who would like to remain, I would like to continue this conversation for a few moments longer and perhaps answer a few more of the questions in the chat, if that's okay. Great. There was a question here regarding, let's see, here, addressing the pervasive toxic culture of humiliation and harassment in academic medicine is often met with defensiveness and/or retaliation from administration, as well as more HR modules put on the resident or student, and usually not those who are actually responsible. Would you agree on this, and what are your thoughts?
I totally agree. And I was fortunate to be doing this kind of work at the same time I was a dean and working in a dean team that was getting very serious about disruptive faculty behaviors, and really developing policies and protocols and actually working with all of the clinical department chairs to find constructive ways to address that, but really to hold a much higher degree of accountability and follow through. So, and it stemmed from probably the fact that our graduating student survey was showing very negative things with regard to those medical student mistreatment experiences. But even far beyond that, it's nothing will shut down a culture of safety and respect like those kinds of hostile outbursts on some erratic or regular basis. So they have to be addressed.
And it sounds like having a sort of foundation, Isabel, like you were speaking to with the HERE committee, sort of having a fundamental safe sort of place or committee or group of people that you can go to in those situations would help tremendously.
Absolutely. I think, these kinds of programs, they work, Christine Moutier and Sid Sissok created something that is extraordinary and it works. But there really has to be buy-in and engagement from the department. So when we're talking about radiology, it can't just be lip service to wellness and lip service to all of these other elements that create an environment that's supportive and fulfilling. If there are toxic elements, they need to be addressed head on. And when that doesn't happen, that actually has a much more detrimental effect overall on burnout and the wellness of individuals and the morale of the group as a whole. So you could have, you could be saying all the right things, but if it's not backed up with action, it can have the opposite effect.
Right. We actually had a question come in prior even to this webinar. It was someone who submitted a question in advance that I would like to share. As I understand it, many, if not most, suicides tend to occur in a spur of the moment situation. Examples would be firearms or jumping off a bridge. Suicide by medication may take more forethought because the individual would have to get those drugs. Do we know if there is a significant difference in the type of suicide by physician and dentists versus others?
Yeah, the method of suicide among physicians is skewed towards poison and overdose, but not completely. There's still a mixture of methods used. And to the point about impulsivity and the timing, it's an interesting thing that the literature really shows, which is that even in the case of impulsive suicides, where the time that between the current episode of suicidal thinking and plans and taking action is on average about 30 minutes, even in those instances, their suicidal thoughts episodically had begun, weeks or months before, and the earlier planning stages had occurred before, and it still can be categorized as impulsive because in that instance there's a very quick time frame. So I say that because it's important to understand that it is not the case that most suicides occur completely out of the blue without a planning period where their distress. Look, we're all very zipped up. We are generally not bringing that into the workplace and talking about those internal experiences, but people as human beings can only be so good at hiding it. And so oftentimes the behavioral indications, like we were talking about earlier, are the ways to detect risk. And I know it sounds so kind of, in a way, hyper vigilant to be thinking, well, someone who's always on time and they're starting to show up disheveled and late, you mean that person? And yes, I do, only because I'm not saying that they are necessarily having a crisis of suicide risk, but they could be, and that could be how it's showing up. And what is the harm of creating a culture of respect and support by starting to engage people in those kind of supportive conversations?
Absolutely. Thank you so much. These discussions today have been really powerful and very moving, and I hope this is really just the beginning of this discussion. I know our panelists also need to wrap up, but I would like to thank you all for your time. I would like to thank my co-moderator who had to go back to work, and all of our colleagues at the APDR and the AUR R&E Foundation, as well as the donors who made today's presentation possible. Before you all go, please visit the SurveyMonkey link in the chat. We thank you all for your attention and for your participation. Let's remember to take care of ourselves and one another. Thank you all.
Yes.
Thank you.
Thank you, Christine.
Thank you so much.
Isabel.
Bye. Take care.
Bye-bye.